The treatment for thalassemia is lifelong blood transfusion along with iron chelation in the form of oral and defiprone and defloxamine subcutaneous twice weekly. And the cure is histocompatible bone marrow transplant. Now, the complication to note in the management, they include if no transfusion, then it may lead to death. And the transfusion, as we have already discussed, that it can lead to uh, iron overload. And
So
if
iron
yes,
iron chelation means like iron is taken out from the body.
yes, these defloxamine and the other drug, oral defiprone, they combine with iron and then they are excreted from the body.
Okay.
So if blood transfusion is not adequate in children, what will happen? Anemia will happen, and due to anemia there will be decreased growth, and due to decreased growth there will be skeletal deformity, such as bursting of the skull, and due to 10 years of repeated transfusion, it can lead to endocrine failure, uh, liver failure, heart toxicity, due to excessive iron accumulation in these organs, endocrine failure or liver failure or heart toxicity, any of them can occur. Beta thalassemia minor is HB is usually above 9 and the patient is usually asymptomatic. So no intervention is required. Only observation is required if the patient is asymptomatic. Alpha thalassemia, they are due to deficiency of alpha chains in hemoglobin. If both of the alpha chains are absent, if all the alpha chains are absent, then what will happen? That it will be fatal in vitro and it will lead to death of the baby inside the womb. And if only one or two alpha chains are absent, then there will be hypochromic and microcytic anemia, but HB level would typically be normal. There are three common types of hemoglobin: A, hemoglobin A2, and hemoglobin F. Hemoglobin A contain 2 alpha and 2 beta chains. This is the normal type of hemoglobin that is present in the adults. And hemoglobin A2, it contain 2 alpha and 2 delta chains. And hemoglobin at F or fetal hemoglobin, and that is usually present in the fetus, it contained 2 alpha and 2 gamma chains. So as I already told you that of all the thalassemia types, you only need to concentrate on beta thalassemia major because patient with alpha thalassemia major, they usually die in utero, and patient with thalassemia trait, they are asymptomatic. So we discuss the complication of beta thalassemia major due to hemolysis in the spleen and in the liver. There will be hepatosplenomegaly or enlarged liver or spleen, and due to extramedullary hemopoiesis, that is synthesis of RBCs outside the bone marrow in the flat bones of the skull, it will result in frontal bossing. You can see in this diagram, frontal bossing is prominent frontal bone due to extramedullary hemopoiesis, which lead to a chipmunk facies, prominent facial bones, and dental malocclusion. And what are the lab findings? Microcytic hypochromic anemia. Serum iron will be elevated. Saturation will also be elevated, and ferritin is also increased because of increased transference saturation. What will happen to TIBC? Will it be increased or decreased? Anyone?
Decreased.
Yes, decrease total iron binding capacity because there is enough iron available for the binding, and that is already bound and they have saturated the transferrin, so total iron binding capacity will be decreased. So far we have discussed three causes of microcytic hypoglycemic anemia: anemia of chronic disease, in rheumatoid arthritis, and in Crohn disease, and the third one is thalassemia. Now, can someone tell me how we are going to differentiate between anemia of chronic disease and thalassemia on the basis of labs?
Anemia of chronic disease, free iron, like total iron will be low, ferritin will be high, that is the storage form, so that total iron binding capacity will be low. And in thalassemia, serum iron will be increased due to maybe blood transfusion or increased iron absorption, and thus ferritin will be also increased and TIBC will be reduced.
Yes, that's right. So we can differentiate
Sir, can
between
you just
what?
repeat? Can you please repeat this?
Yes, anemia of chronic disease and thalassemia can be differentiated on the basis of labs, just on the basis of serum iron. Elevated serum iron means thalassemia, and decreased serum iron is anemia of chronic disease. Now, someone can ask that there is a decreased serum iron in anemia of iron deficiency anemia as well. So, how we are going to differentiate between iron deficiency anemia and anemia of chronic disease, because both of them has a decreased serum iron or free iron. Between them, we can differentiate on the basis of ferritin and TIBC. In iron deficiency, because no iron is available, so stored
So,
iron will also be decreased, that is decreased ferritin, and transferrin saturation will also be decreased, which means an increase in the total iron binding capacity. So on the basis of these 2 points, we can differentiate between iron deficiency anemia and anemia of chronic disease, that is ferritin and TIBC. So what happens to TIBC in anemia of chronic disease? What will happen to TIBC in anemia of chronic disease? Anyone?
Decreased.
it will be decreased
Why it will be decreased?
because there is iron is not enough to bind with the. There will be decreased iron as well.
No, there will be increased the store form of iron, that is ferritin.
There'll be storage, raised storage form of
If there
ferritin.
is if there is sufficient iron available, then TIBC will decrease because iron is available to bind. TIBC mean binding capacity.
Binding capacity. Yeah.
So if sufficient iron is available, as in case of anemia of chronic disease, so TIBC will be decreased. But sufficient iron is not available in iron deficiency anemia. So in iron deficiency anemia, TIBC will be increased and ferritin will be decreased.
So, but in anemia of chronic disease, otherwise the iron would it be decreased?
Again, the total iron is, you can say, uh, there is no problem with the iron. Iron is available sufficiently in the blood.
Yeah.
But the question is about the form of iron that is available. So iron is not available in free form due to inflammatory cytokines. So serum iron will be low because iron is not available in free form. It
Yeah.
is either available in bound form with transferrin or stored form in the form of ferritin.
Oh, okay, okay.
So focus on the basic point, that is sufficient iron is available in anemia of chronic disease, but the form in which it is available is different. It is decreased in the free form and increased in the storage and bound form due
Right,
to, again, due to inflammatory cytokines.
right.
But in iron deficiency, sufficient iron is not available. Free form also not available, bind form also not available, ferritin form also not available. So think like that and you will never get confused. The definitive diagnosis of thalassemia major is made on HB electrophoresis, which will show an increase in HbA12. X-ray in patient with beta thalassemia major will show a hair on end appearance because of extramedullary hemopoiesis. An X-ray skull will be like this. You can see that a hair-like projections are present on X-ray skull. This is known as hair on end appearance. So initial investigation will be complete blood count, which will show microcytic hypochromic anemia, and iron studies, which will show elevated serum iron, uh, raised saturation or decreased TIBC, and increased ferritin. And X-ray will show hair on end appearance. So the fourth and the last cause of microcytic hypochromic anemia is sideroblastic anemia. It is a rare cause of microcytic hypochromic anemia. It is not important for Plab 1 exam, but you still can remember it for your knowledge. The fourth cause of microcytic hypochromic anemia is sideroblastic anemia. Why it is called sideroblastic anemia? The first question is that. And the second question is that how microcytic and hypochromic anemia or microcytosis occur in sideroblastic anemia. Remember that, again, there is no problem with the iron in sideroblastic anemia. Remember that we discussed that there are two parts of hemoglobin. One is heme and the other are globin chains. Heme is synthesized, half part of the heme is synthesized in the cytoplasm or cytosol, and the other half is synthesized in the mitochondria. An enzyme is there is an enzyme that is used in the synthesis of heme. This enzyme is known as dehydrogenase. You can say that this enzyme basically incorporate iron in the heme ring. In sideroblastic anemia, what happens that this enzyme is either absent congenitally or it is there's a defect in this enzyme. So the iron will not be incorporated into the heme ring. So what will happen? The iron will accumulate around the nucleus of the RBCs in the form of forming a ring-like structure that is known as sideroblast. You can see this blue color deposition of iron around the nucleus of RBCs. This structure is known as ring sideroblast, and this anemia is known as sideroblastic anemia. Ring sideroblasts are basically erythroblasts with iron loaded mitochondria visualized by this iron is loaded into the mitochondria, and these mitochondria form a circle around the nucleus, and they can be visualized by Prussian blue stain in the form of a perinuclear ring or blue granules. So that's why it is called sideroblastic anemia. So the first thing that you need to remember about sideroblastic anemia is that there is no problem with the uh, iron, there is no problem with the globin chains. The problem is in the synthesis of heme because iron is, you can say, cannot be uh, incorporated into the heme due to defect in the enzyme. The enzyme that is LR dehydrogenase that is involved in the formation of heme that is deficient or defective. This deficiency can be congenital, which will be known as congenital sideroblastic anemia, or it can be acquired. It can be caused by drugs such as chloramphenicol, fusidic acid, linezolid, tetracycline, isoniazid. There are multiple drugs which can cause sideroblastic anemia. And you can remember the second point about sideroblastic anemia, that if ring sideroblasts are seen on a peripheral blood film, then your diagnosis will be sideroblastic anemia. It won't usually be asked in the Plab 1 exam because it is a rare condition. So you would just need to remember these 2 or 3 points about sideroblastic anemia. One is that it causes microcytic hypochromic anemia, and there will be there's a defect in the enzyme that is involved in the heme synthesis, and due to this defect, iron is not incorporated into the heme, and they accumulate in the mitochondria, and mitochondria form a circle around the nucleus of the erythroblasts, which give it an appearance of uh, ring sideroblasts, and this is known as sideroblastic anemia. You can see in this picture and in this picture as well, the blue stains or the blue granules that are surrounding the nucleus of this RBC. The last cause of microcytic hypochromic anemia is lead poisoning. Lead poisoning or lead can also inhibit this enzyme that we are talking about, LR dehydrogenase, that is involved in the heme synthesis. So it can also cause, because it interferes with the synthesis of heme, so it will cause microcytic hypochromic anemia along with acute intermittent porphyria. The metabolites of uh, heme synthesis, when they are released in the, such as porphobilinogen, and the other one when they are excreted in the urine, it is known as porphyria. So lead poisoning causes microcytic hypochromic anemia and intermittent porphyria. The patient will present to you with fatigue, constipation, abdominal pain, peripheral neuropathy, and this is an important point, blue lines on gum margin. Though it is present in 20% of the adult patient, it is very important to remember to make a diagnosis of lead poisoning. The diagnosis of lead poisoning will be confirmed on blood level of lead. A blood level of more than 10 microgram per deciliter are considered significant poisoning. Full blood count will show microcytic anemia. Management is chelating agents such as DMSA, dipencylamine, EDTA, and dimercaprol. Any of them can be used to remove lead from the body. So this was all about microcytic anemia and its causes. The most common cause is iron deficiency anemia. Then there is anemia of chronic disease. Then there is thalassemia. Then there is sideroblastic anemia. And then there is lead poisoning. I hope the causes of microcytic anemia is clear to everyone.